All right. Last one before we get in that lab. Frontal sinus surgical pearls. So I'm going to go through a lot of this stuff. Some of this stuff has been through kind of the course of yesterday and today, a little bit that we've hit before, but I think these are all the key points. So how to optimize results. So I'm not going to go through all the anatomy, but I really want to think about how to optimize results. So first off, when we think about it, we think about our preoperative treatment. So what type of patient is this? Is this a polyp patient? Is this no polyps? Is this something that you want to consider some preoperative steroids and or antibiotics? I don't use them in most cases, but there are some cases I've regretted and said this life would have been easier with that. I mean, the data has shown that if you've got a polyp patient, you're going to have less bleeding from preoperative steroids. So think about if it's something that you think may be a challenge, think about some treatment beforehand. And then when you actually look at the CT scan, what we're going to do is talk about the key points for me that I honestly think about from a frontal sinus dissection standpoint. So the first and foremost is that AP diameter. So right away, I'm looking at that because honestly, if that diameter is large, even if the bone is thick, it's still pretty straightforward. Conversely, if you have that narrow anatomy there, you're going to struggle a little bit, even with even more straightforward cases. Secondly, and we're going to talk about this on some other examples, is the frontal cells. How many cells do you have up there? What exactly is going on with those cells? And then finally, landmarks. So if this is a primary case, you're likely going to have good landmarks. But if it's not a primary case, what is the issues with, like, how much in that turbinates do you have left? What type of anatomy has happened before from a surgical standpoint? So think of those three kind of big picture. And then the last one I spend a lot of time looking at is osteotic bone. I joke with my fellows, like if you have a minimally diseased frontal, you can just go like a bull in a china shop and it'll open up no problems. But when you have that osteotic bone, that's where you really have to think about your dissection a little more thoughtfully because the instruments with how you're cantilevering them, they don't have the strength to get through a lot of bone unless you're really thinking about the pathways that you can go through. Other factors, we talked about the anterior ethmoid arteries. I'm not going to belabor those anymore, but do think about skull-base asymmetry, think about skull-base dehiscence, and also that lamina papretia because you're really going to be dancing on that lamina as well. So when we think about intraoperative maneuvers, I do think about all these factors that you see there. From an improving visualization standpoint, hemostasis is your friend. I love 1 to 1,000 epipledgets. I'm a person, I know traditionally a lot have been taught to like finish one side and go to the other side. I love going back and forth. And this is not just my frontal sinuses. The second things start to get bloody a little bit, I pack it off and I go to the other side, assuming you're doing bilateral fess. The frontal is no different, that I really like to pack it off and go and switch over to the other side. Obviously, we talked about this head-to-bed elevation. TIVA is helpful. And then the other thing that from a training standpoint, and I think we all instinctively do this, is when we're in the frontal and we're trying to look at the anatomy, you wind up suctioning a lot, suctioning to try and see things. Well, when you keep doing that, you keep traumatizing that mucosa, and it just tends to bleed a little bit more. So do your best to really have like a very focused suction when you're doing that. You're just not helping yourself. Angled scopes are the key. There were some examples, I can't recall who did it, but it was a beautiful example looking at the differences of what your visualization is with the 0 to 30 and the 70-degree scope. So I'm a big 70-degree scope user for the frontal sinuses. I think a lot of people also use the 30s and the 45s. Nothing wrong with any of these, but you really do need that angled scope to get good visualization. And then identifying the outflow tract itself. So Raj showed earlier, there have been a number of different classifications. I mean, there was the original classifications, talking about the type 1, the type 2 cells, et cetera, and then there have been multiple classifications since then. Quite honestly, it doesn't matter. I really have not gotten too caught up in the types of cells. You're really just thinking about what are these cells doing to your frontal recess pathway. And what I mean by that, this is a fairly simple example. So these would traditionally be looking at, this would be your Agernazi and your type 1 cell there. And all you're saying is, okay, you've got these cells anterior. That means that drainage pathway has to be right behind that, right? So that's really what you're thinking about. Or here you've got this interfrontal sinus cell, and that'll typically, I think Craig said this earlier, that'll typically push your frontal recess pathway laterally. So you really just have to understand what the cells are doing to where you're trying to get to. And this was a little bit a picture, again, very similar to what we looked before, but this is me when I'm thinking about looking up with my 7-degree scope, and you're like looking up high. This is a left frontal recess dissection, and you see where anterior is. And what we know is that Agernazi cell is going to be anterior to that drainage pathway. So where we find that Agernazi cell, you know the pathway is going to be posterior to that. If you have any of those anteriorly based frontal cells, those cells are also going to push you posteriorly. So those cells are always going to be anterior to where that drainage pathway is. What I pointed out before is that intersinus septal cell, that's going to push your drainage pathway laterally. And then if you have either a supraorbital ethmoid or a suprabular cell, those are posterior to frontal recess. So again, all you're really trying to identify is these cells, and the names don't really matter. You just want to know what those cells are doing to your recess and what you're looking for. A word about image guidance. I mean, I use this for all my frontal sinus surgery. It makes me a better surgeon. The big thing for me is, and I've consulted with all the image guidance companies at some point, and they all say they're always 100% accurate, and I think we all know they always have some sort of errors here and there. So I don't use it for any actual reliance on how to get in the frontal sinus. Really what I'm using it for is for this triplanar view. So all it is basically our old school, when we had the light box and you'd go up to the light box and you take a look at all your films, literally all you're doing with this is you're getting that triplanar light box. And once I see that anatomy, then I know what I'm looking for. Okay, so if there's a big suprabular cell, I'm looking for a suprabular cell. And once I see that, I know that frontal recess is right anterior to that. So we're not really using it for true image guidance, but really more for essentially helping us for mapping things out. And once you find the frontal sinus, well, how are we going to enlarge it safely? So this is a nice one. One of my mentors used to say that frontal sinus recess pathway is where you see it's right dark right there. And so once you see that area, again, if you know your anatomy here, what we're looking at, we're like, okay, there's got to be an auger in front of this, and there's that suprabular cell right behind it. So how can we open these? So we typically, or I like to typically, to get to this phase, I like to work anterior to posterior. Again, anterior is always safe. You literally can take an instrument against that auger and that frontal beak, and you can pick the patient's head up off the bed with that anterior beak, and you're still safe. Posterior, you got to be more careful, obviously. So that's why I like to always go anterior. So if you start getting in there, look for those cells that you have anteriorly. So here's a nice schematic on a sagittal view, where essentially here you've got, again, an auger, and you've got a cell right above that. So here, when you're opening it up, get those anterior cells first. That's really what's going to get you that room there. And then if you were getting an intraoperative CT scan, this is what you'd be looking at. You'd essentially have taken these cells down, and you've opened it nicely already there. And then once you get that anterior aspect done, that's when you work on the posterior side of things. So that's where then I'm going to take whatever cells you have, whether it's a suprabular cell or supraorbital ethmoid, but you're going to then take that bony partition up. So essentially what you'd be doing is taking this partition down here in that maneuver, and that's where you're getting that wide open recess that you really want. And then we talked about anterior ethmoid arteries. Like I said, I'm not going to say too much about them, but we definitely want to make sure for all your dissections in the lab today, make sure you find that vessel and get a good feel for where that is. While it's not exactly constant, there are some constants about that vessel. I think Arya mentioned RF actually mentioned that we were talking about that horseshoe shape. It is pretty classic that you've got that frontal sinus recess pathway, then there's typically one cell, and then you're going to see that anterior ethmoid artery right there. So in most cases, it is right there. So make sure you find that. And then maintaining patency. There's a number of different ways to do this, from putting nothing in the frontal sinus. Obviously, there's a lot of drug-eluting stents. Pen is very cheap. They never wanted to pay for that for us, so we don't have those. We go very cheap. I use silastic stents. And we call them stents, but essentially they're a thin piece of plastic that essentially is putting essentially a dressing over that denuded mucosa there. So we typically put these in and leave them in for a couple weeks, and the mucosa really mucosalizes well around there. And then even when we're debriding them in the office, it's very nice to see that little piece of plastic, because when you're really bloody and swollen and edematous in there, I can just follow that up with my suction. So I can literally follow that pathway up. So I know I'm getting into the frontal, and then I typically take it out in a couple weeks, and they do pretty well. And then post-operatively, I do keep most of my patients, if there's no contraindications, on a low dose of steroids for a little while. Aggressive saline rinses, I mentioned about the stents, and then obviously topical steroids post-operatively. So then the last question for me when I'm thinking about doing a standard, so my workhorse is draft 2A. That's what I'm doing in most cases. So essentially identifying that frontal, opening up just like you saw there. So where am I doomed for failure? And that's where I'm thinking about from my standpoint, because my practice is a lot of revision cases. So I'm thinking about those areas. So one is heavy polyp patients, that osteotic bone, and this what we can talk about if we have time in the lab, is a lot of frontal sinus cells. So this patient to me is just going to struggle even if I do 2As, because this patient needs really good topical access to get those steroids in. I don't think you can get that good topical access without really opening those sinuses up really widely. We don't have it, but for the interest of time, we've done some really nice studies with computational fluid dynamic models, and essentially you can see the amount of irrigations that get in with the draft 2A, 2B, and 3. And the 3 for the frontal is, as you can imagine, much more impressive, and I think that helps with getting your steroids in there. And then osteotic bone. So this was a patient that has just stayed very infected in that area, has had some other procedures done previously, including some more minimally invasive procedures. And the problem is, I think they were able to get in every time, but because it's so infected and that bone is so osteotic, it just kept closing down. So that's a case that typically I'll go much more aggressive and either do a 2B or a 3, really to get this bone down here and get that nice and open, because the integrity of that mucosa you're really gonna struggle with. And then for the last one, this is an interesting case. So this is a case of mine where I failed. So this patient essentially had a lot of cells everywhere, including this frontals, and you can see all those little cells up there. So I had taken him into surgery and opened up the frontal, standard 2A for me, again, seeing these cells there, and I felt I'd gotten into him, but he just kept having infection after infection, headaches in the frontal recess area. And this was his oh, come on. Codec not available. I don't know. It's okay. So just for interest of time, essentially it was a video that showed when you looked endoscopy-wise that actually had gotten into all these recesses, and those cells were open. It's just that this patient had inflammation around all these cells. So it wasn't just an aeration pattern, it was just inflammation throughout that whole area. And then this is 7 years later. Will this code? Of course not. So here I had to open them up much more aggressively with the drill. Now, going back to, I think there was a point brought up before, which I think is valid, is how many, if we get into these cells on a number of patients, how many patients do well versus do poorly? That we really don't know the answer to. Like I said, I'm biased on the side that I'm seeing the ones that get to me as well. But for me, when I see a lot of those cells and I see inflammation around the cell, so it's not just obstructive, those are the ones I am more aggressive with, because I think just kind of aerating those cells is not enough for me. I really need to get in there and open those up. So in conclusion, plan your tact on that frontal sinus beforehand. Once you identify that recess, optimize it both for topical access and prevent stenosis, and then identify cases that you're set up for a failure, because those are the cases you want to think about whether you want to go after them in your traditional way or do we want to be more aggressive. Thank you.